Dr. Karpaya, can you hear me?
கேட்கல சார்.
கேக்குதுங்களா? ஹலோ
ஹலோ.
உங்க வாய்ஸ் கேக்குது. நான் பேசுறது கேக்குதுங்களா? ஹலோ
சார் கேட்கல சார். ஒரு சார்.
நீங்க பேசுறது கேக்குதுங்க.
ஓகே சார்.
நான் பேசுறது கேக்குது இல்லீங்களா?
கேக்குது சார். கேக்குது சார்.
ஓகே. ரெண்டு பேர் தான் இருக்காங்க. விக்னேஷ் is not there, is it?
நான் கால் பண்ணிடுறேன் சார்.
Or is he in another screen name?
அவனுக்கு கால் பண்ணிட்டு வரேன் சார்.
Okay. We'll start once Dr. Rajendran joins. So he should join by 2 o'clock.
Hello. Hi, sir.
Yeah. Rajendran sir, good afternoon.
Good afternoon, sir.
Good afternoon, sir.
So we start again?
Start பண்ணிடலாம் சார்.
Yeah. Good afternoon to everybody. On behalf of IAP TNSC, I welcome students as well as faculty from Sri Lakshmi Narayanan Institute of Medical Science, Puducherry. On behalf of IAP TNSC, I welcome Dr. Tirumurugan. He is a senior consultant pediatrician and neonatologist from AG Padmavati Hospital, Puducherry. I welcome Dr. Tirumurugan.
Thank you, sir.
I welcome Dr. Karpaya Pandi.
Thank you, sir.
Associate Professor of Pediatrics, Sri Lakshmi Narayanan Institute of Medical College, Puducherry. I welcome Dr. Karpaya.
Thank you, sir.
I welcome Dr. Vignesh Abilesa, Ariyumadi, students from the same institute. And again, I welcome all the students and faculties who is going to attend this event another 1.5 hours. This actually it's a 13th case presentation for conducting by EAP-TNSE, and it is one of the things we are doing regularly every Saturday, and every Saturday we are having 7:30 to 9:30 postgraduate clinic also. This is under IAP-TNSE and as well as DIEP platform we are doing, and I welcome one and all for this wonderful event. I think hope all the students should be benefited, and I think that Thirumurugan is coordinating this teaching program today, and please take over, Thirumurugan.
Thank you, sir. Thank you, sir. Good afternoon, everybody. I think it's indeed a pleasure to be associated, to be associated with the undergraduate clinics of pediatrics. It gives us a lot of insight into the case discussions, and it kind of so I enjoy it, and I hope the rest of you also would enjoy the same. And I'm happy to have Dr. Karbaya Pandey, who was an ex-Tipmarite just like me, along with me. And I think without any further delay, we'll go into the case presentation. Can we start, please?
Yes, sir. Myself, Arivamati, final year medical student from the Anthropometry Institute of Medical Sciences. Very good afternoon, sir. Am I audible?
Yeah, please
sir?
go ahead. Yeah, can you just get your mic a bit closer? I think the volume is a bit low.
Okay, sir. Now, sir?
Yeah, maybe a bit better. I mean, the questions can be answered just not by the presenter, but anybody else also. So just don't think it's just a one-to-one interaction. We'll encourage others also to answer either in the chat box or directly on the phone. But otherwise, you please keep your mics muted. Okay, please go ahead.
3 years, 10 months old male child, Master Thirukumaran, was born to non-consanguineous parents from Thirukanur, came with mother as informant, which is she is having good reliability. She brought a son with she complained of puffiness of eyes and face for about 10 days, swelling of lower limb and upper limb for 5 days, abdominal distension for 2 days. So history of presenting illness, child was apparently normal 10 years back, and then he developed puffiness around the eye and face for past 10 days. Which was insidious on onset, gradually progressive, from initially involving the periorbital region to involving the whole face, which is more pronounced during the earliest morning, and then decreases as the day progresses. So this history itself will give us clue that they probably be the renal cause, because it is around the periorbital region and more pronounced during the early morning.
Okay.
Then the
So can you tell me what are the possible causes of periorbital puffiness?
Yes, sir. It can be because of liver cell pathology, liver cell failure, liver pathology.
Okay, so we are looking at causes of facial puffiness. So one, you think there will be some systemic diseases, there could be some local causes, isn't it? So systemic one, you said could be renal. Second one is liver. Anything else?
Liver, nutritional deficiency.
Okay, it could be possibly a nutritional deficiency.
And congestive cardiac failure.
Okay, you think it could be a heart problem.
Local causes like insect bites, some bee or wasp bites can cause edema around the eyes.
Okay. Anything else?
Systemic is for liver, renal, nutritional edema, and congestive cardiac failure.
Okay, fine. So so among these, you just forget about this case. Think about a child itself. How common is? Can you order them I mean, based on the incidence, which is the most common in children?
You mean the cause?
Yeah, which is the most common among the ones which you have listed? Which is the most common?
Probably the congestive cardiac failure.
Okay. So you think congestive cardiac failure is probably the one which commonly presents with puffiness of face in children. Is that right?
No, sir. Cardiac edema will start from the lower limb. It will be more in the lower limb.
See, no, the question is very simple. We are now looking at facial puffiness. So you listed 4 causes. You said it could be a renal, it could be liver, it could be cardiac, or it could be a nutritional. Okay. So among these, which is the most likely event to cause a facial puffiness in children?
Renal pathology.
Okay, you think it is renal. Okay. Okay. Somebody else is Abhilasha has mentioned it as nutritional. Okay, so probably they are the most common causes. So why is it that a cardiac cause you don't get a facial puffiness in children that commonly? Anybody else?
Cardiac
I don't want to stick with only Ariyumadi. Anybody else can unmute and this thing. Yeah, Vignesh also has told. So Vignesh, why do you think cardiac is? Can you just unmute? And then
Yes,
tell me,
sir.
why do you think
Because
cardiac is less likely to cause a facial puffiness in children?
if you lie supine, only the facial puffiness you can appreciate. Cardiac people cannot lie supine. They have to
Okay.
be in recommend position because of CCF pulmonary edema will be present. They can't lie supine.
Okay, fine. That's probably, I mean, you are probably half right. Anybody else who could make it better?
They will be having orthopenia.
Okay.
Orthopenia. So they will be having disturbed sleep. They will not get a very sound sleep for prolonged period.
Abhilasha, do you want to try?
Sir,
Anybody else from the audience? See, please remember that when you look at congestive cardiac failure by itself, okay, it's not, sorry, the right heart failure, sorry, the facial puffiness is a feature of right heart failure. Okay, and conditions causing right heart failure as such in children are very limited. Okay, so whatever conditions which you see which cause congestive cardiac failure is more common with the left heart failure. And number 1, and number 2 is you need to have a very long standing history. By then the child becomes presents with the other conditions. So the child very rarely presents with the facial puffiness in children, unlike adults. Okay, so I agree that yes, they don't lie alone, they keep roaming around a lot, so all those contributes to the fact that they don't develop facial puffiness. But more important, you need to remember that facial puffiness is more a feature of a right heart failure rather than a left heart failure. Okay, fine, go ahead.
The mother noticed swelling of bilateral lower limb.
And you said that the facial puffiness is more common in the morning, so why does that happen?
Steroid levels are more increased during early morning.
Sorry?
Steroid levels are increased early in the morning.
No. Okay.
The child will have prolonged lying flat in the bed.
Yeah,
About
basically
8
it's
hours.
redistribution of the fluid, number 1. Number 2 is you have very lax subcutaneous tissue, sorry, fat with, so there is a lot of place for the fluid to get accumulated. That's why facial puffiness is, particularly the periorbital puffiness, is more common in the morning. Fine.
Fine. Shall I continue, sir?
Yeah, please go ahead.
The mother noticed the swelling of bilateral lower limb after 5 days, which was insidious in onset, gradually progressing from feet to knee, then in the upper limb from hand to elbow, more during morning hours, and then decrease as the day progresses. So as the child mobilizes, the edema will subside gradually.
Okay, fine. Again, it
After
suggests
3
that,
days,
okay, this could be a renal problem. Okay, fine.
One minute, sir. After 3 days, mother noticed generalized abdominal distension and not associated with abdominal pain. Mother also noticed a reduction in both frequency and amount of urine passed for the past 2 days. Initially used to pass 6 to 8 times per day, so the urine output is reduced for the past 2 days. Presently passing 3 to 4 times in reduced amount, also concentrated urine.
Okay, so all put together so far, what do you think is the primary problem in this child?
Some renal pathology, sir.
So, okay, you think it is a renal pathology. Fantastic. So, what are the renal pathologies which can present with this kind of presentation?
Mainly oliguria can be of nephritic cause or nephrotic cause.
Okay, so it could be a nephritic syndrome, or it could be a nephrotic syndrome, or it could be a primary renal failure. Okay, fine. So let's concentrate only on the nephritic and nephrotic. So how would you differentiate between the two based on the history? Please go ahead.
Nephrotic syndrome is more common in children like 6 to 10 years of age. Whereas
Okay.
nephritic syndrome is common in older children. Then in nephrotic syndrome, the child presents with edema,
Okay.
primarily followed by oliguria. Whereas in nephritic syndrome, the child will primarily have hematuria, and then edema will develop after the urinary symptoms. So the main thing in nephritic is cola-colored urine.
Okay, fantastic. Go ahead.
And regarding the urine examination.
Yeah, we'll go ahead. We'll come back to the later, but anyway, we'll just stop here. You continue with the presentation.
Yes, sir. No history of cola-colored urine, headache, blurring of vision. This history is more suggestive of nephritic syndrome. So this child is having a negative history of cola-colored urine, headache, blurring of vision. So our history is going more towards nephrotic cause. No history of breathlessness on exhaustion, recurrent respiratory tract infections, chest pain, syncope. No history of decreased physical activity, reduced appetite, and failure to thrive. No history of jaundice, eye-colored urine, hematemesis, blood and stool. So we are also ruling out the liver pathology, which may lead to the edema in the child. So next thing is no history of fever, weight loss, bony pain, blood transfusion, skin rashes, joint pain, sore throat, drug intake. This history will help us identify the cause of the nephrotic syndrome. So weight loss, bony pain will track us towards the secondary cause like SLE. Blood transfusion, hepatitis is also one of the secondary cause of nephrotic syndrome. So we are ruling out that also. Skin rash, joint pain, sore throat, drug intake.
Yeah, you carry on, carry on.
Yes, sir. No history of crying during micturition, no history of abdominal pain, vomiting, reduced appetite, loose stool, hurried breathing, chest and drawing. No history of headache, atrosensorium, weakness of limbs and seizure. So we are ruling out the complications of nephritic syndrome. Past history, no history of similar illness in the past.
Go back the previous slides. So your presenting illness is over.
Yes, sir.
Go back to the previous slide. Why you asked headache, seizure, altered sensorium?
To rule out the cerebral thrombosis, which is one of the complications of nephritic syndrome.
Okay, then any other cause?
That's all, sir.
Rule out hypertension, we can ask that, sir.
Okay, so in which condition hypertension will be more common?
Nephrotic syndrome.
Nephrotic syndrome.
Okay, so nephritic syndrome, they will produce hypertensive encephalopathy that leads to seizure and headache and altered sensorium. Okay, why you ask negative history of decreased physical activity, reduced appetite, and failure to thrive?
Some protein energy malnutrition.
Nutritional cause.
Okay, which among the protein, which will cause anasarca?
Kwashiorkor.
Kwashiorkor. Okay, good.
Okay, just to join, what is the difference between generalized edema and anasarca?
Anasarca will be also adding pleural effusion, ascites.
No, that's not the right answer. Anybody else? Hariharan. I don't know if he's there. No, Hariharan. Hariharan. Okay, yeah. Yeah, anybody else can join in. Prashant. Okay, anybody else? Even among the present, Abhilasha, would you like to try? No. See, please remember that the only difference is the presence of genital edema. When you have genital edema, you call that as, along with the generalized edema, you call it as anasarca. In the absence of genital edema, it is just a generalized edema. Okay. Do you understand?
Yes,
So
sir.
generalized edema plus genital edema, you call it as anasarca. Without it, it's just only generalized edema. Okay. Okay. Move on.
So past history, no history of similar illness in the past, no history of sore throat, no history of skin infection, no history of tuberculosis. Treatment history, the child was not on any regular medication.
Okay, no, just go back. Go back. Can you just go back onto that? You said no history of sore throat and skin infection. Why is it relevant in this case?
Sore throat will point us towards the diagnosis of post-streptococcal glomerulonephritis.
Okay, possible. Any other relationship to nephrotic syndrome itself? Sore throat and nephrotic syndrome. Anything else?
The streptococcal infection itself can cause nephrotic syndrome. So post-nephrotic
Fine.
syndrome.
They don't cause, they can kind of precipitate an episode of nephrotic syndrome. I mean, very well done. A very good answer. Okay, fine.
Skin infection like infective also, streptococcal infection can cause infective.
Yeah, go ahead, please.
Antenatal history, booked, immunized, taken iron and folic acid tablets regularly, no history of exanthematous fever, drug intake, and no history of radiation in the first trimester, no history of pregnancy-induced hypertension, gestational diabetes mellitus in second trimester, no history of bleeding, no history of bleeding PV in third trimester.
Okay, go back to the slide. Madi, go back to the slide. Okay. Why you asked the history of exanthematous fever in first trimester? What do you think?
Torch
Infection can lead to secondary nephrotic.
Okay, fever with rash and post-auricular lymphadenopathy. It gives any clue? The first trimester, mother having fever with rash with post-auricular lymphadenopathy.
Cytomegalovirus.
No.
Post-auricular lymphadenopathy is pretty characteristic of some other infection.
Diphtheria.
No, torch infection. Which infection will cause? Anybody? Yeah, Prashant, yes. Answer rubella. Good. So rubella,
Yeah,
the symptom of rubella. Can you anybody tell the triad of congenital rubella syndrome?
Cataract. Deafness.
Congenital rubella syndrome. Triad.
Vignesh doesn't want to show his face.
Hello?
Also, he hasn't turned his video on.
Congenital rubella syndrome, sensorineural deafness, sir.
Yeah, very good.
Ocular manifestation like retinopathy.
Okay. No, not retinopathy. That is comes under something else. Cataract. Yeah.
Cataract and a congenital heart defect.
What lesion in congenital heart defect?
PDA.
PDA, cataract, and sensorineural hearing deafness. Okay. Okay, Aryu, go ahead.
Birth history. Full term, normal vaginal delivery at Jisma. Cried immediately after birth. Birth weight was around 3.2 kg. Breastfeeding started 30 minutes after birth. Postnatal history. No history of breathlessness, jaundice, fever, and convulsions. No history of NICU admission. Developmental history. All the developmental domains achieved till date. Child has not yet joined school. Immunization history. Immunized up to date according to National Immunization Schedule. Optional vaccines are not taken.
Okay. So developmental history, go back to the previous slide. Can you tell gross motor, fine motor development attained at 3 years of age?
Neck holding spine. The child has
3
developed
years
neck
of
holding.
age.
At 3 years, what are the milestones you would expect the child to achieve?
The child can identify the age, sex.
Okay.
Child knows name, gender.
With the motor milestones, what motor milestones you can think about?
The child can go upstairs and go downstairs.
Can be a bit more specific?
Can ride tricycle, sir.
Okay, tricycle is one, but going back to climbing stairs, how you? There is something very specific about it.
Alternate feet going upstairs.
Climbing up and down with 1 foot.
And when they come down?
Come down 2 feet.
With both feet. Okay, very good. Then what else?
Then fine motor.
When does the child start walking backwards and sideways?
It is called cruising.
Sorry?
Cruising, sir.
No, cruising is something else. No, my question was see, we are talking about child walking forward, isn't it? I'm asking about a child. When does the child can walk backwards? I think all of us can walk backwards, isn't it?
Yes, sir.
So when does a child can start? When did we learn to start walking backwards? Okay, it is at 18 months. Okay, so much before than what we think actually. Okay, fine. Go ahead. So what about the no development only? Why you want to run away from development? Very interesting. So what about the rest of the cognitive milestones which you can talk about for a 3-year-old? You said
Fine motor.
knows age and sex. Anything else?
Then social can play with
3 years fine motor, sir. They can make a tower of 9 blocks and they can copy a circle. Hello, is it audible, sir?
Yeah. You are audible.
They can copy a circle. And for social and adaptive skills, 3 years they can share toys.
So what else you can do? What else you do? Give it. You can always ask a 3-year-old to write something, isn't it? Give a pencil, pen, and then ask them to do, isn't it?
They can.
What do they can do at 3 years?
they can draw circle.
Yes, very good. They can draw a circle at 3 years.
3
Okay,
years.
very good. And if you ask them to draw a man, how much will they be able to do?
Fully they can draw, sir.
Sorry? They will draw a face with 2 parts,
Face.
whatever. So it's basically 3 years is 3 parts. That's what you need to remember. Okay? Face with 2 parts. Okay. Fine. We'll just a bit more on the immunization history. So what was the various immunizations the child exactly took?
Child is 3 years old. So she might have taken OPV booster.
At
But
birth,
what the child should have
BCG.
taken? Yeah, BCG.
At birth, BCG, hepatitis B virus, and oral polio virus vaccines are given.
Okay.
And at 6 and then 4, 6 and 6, 10 and 14th week, pentavalent is given. Oral polio vaccine is given.
Okay.
Then rotavirus vaccine is given. At 9 completed weeks,
No. Rotavirus
measles
vaccine
vaccine.
where? Pondicherry கிடையாது. Patient is from Tirukannur, no?
Yes, sir.
Pondicherry, Tamil Nadu. If they are from Tamil Nadu, then they would have got rotavirus. But if they are from Pondicherry, they wouldn't have got rotavirus vaccine. Okay, fine. And something else you have forgotten, very important. Apart from OP, what else they would have? They would also got injectable polio. Okay.
IPV.
Fractionated IPV.
6th
And
and
IPP,
14th
what,
week.
how is it given in the government schedule?
6th and 14th week.
And through what route?
Intradermal.
Very good, very good. Well done. Okay, fine. Then at 9 months MMR, then
9 months MMR and
Vitamin A doses given.
okay.
vitamin A
At
doses are
12 completed months, Japanese encephalitis virus vaccine is given.
Okay, again in Tamil Nadu, not in Pondicherry, other some districts only. Okay, fine. Then
Measles vaccine.
In 16 to 35 months, DPT booster is given.
Sorry for the interruption.
Yes, sir.
So actually, that injectable polio, many a times they are giving with DPT combination only, and they are giving IM.
Yes, sir. India on the government level, they are giving it as intradermal, sir.
Yeah, government level intradermal, and
Intradermal.
mostly
Yes, sir.
that they are giving IM only.
Yes, sir. Agreed. Okay. Yeah, at 15 months, what do you give?
24 months DPT booster is given.
No. 15 months.
15 months. MR second dose, sir.
Just 1 minute. 1 minute. Okay, you carry on with your this thing. You carry on.
Okay. What are the optional vaccines they will give, Arivamadi? In nephrotic syndrome, so related to nephrotic syndrome, what are the important optional vaccines?
Pneumococcal vaccine.
Okay.
Influenza.
Okay.
Varicella.
Varicella vaccine. Okay. Okay, are you continue that?
Child history. Child was exclusively breastfed till 6 months of age. Complementary feeds were started around 6 months of age. Breastfeeding stopped by 1 year of age. The expected calorie intake for a child is 1,200 calories per day. The child has taken 950 calories per day, so the deficit is around 250 calories per day. Expected protein intake is 21 grams per day. The child has taken 21 grams per day, so the deficit.
So
okay.
how sorry. Yeah, go ahead, Dr. Karpaya. Please go ahead. Yeah.
Any bedside method to calculate the calories and proteins?
Cal 24 hours.
24-hour recall method you can do, sir. Hello.
24 hours recall method, sir. We can ask what another child.
Okay. Any other simpler method in the bedside? Any formula, holiday sagar formula, do you know?
Yes, sir.
Okay.
Less than 10 mg is 1000 calories. At 10 to 20 mg is 1000 calories.
MG, kilograms.
Kilogram.
1000 kilocalories plus 40 into the in weight. Greater than 20 kg, it is 1500 kilocalories plus 20.
Okay, fine. Please move on.
Type of family is nuclear family. The child lives with parents and 2 siblings. Sorry, 1 sibling. The sibling is around 8 months old, healthy girl child. No abortion or no stillbirth. No history of hard of hearing, visual disturbances, renal stone, hypertension, diabetes mellitus, TB, and asthma in the family.
Okay, so just once again, go back. Among all the negative histories you are told, which is the most important one among whatever you said? Which is the most important history I would be interested in? You got deafness, visual disturbance, renal, hypertension, diabetes, tuberculosis, asthma. Which one is most important and why?
No history of tuberculosis in the family.
Okay, why is it very good? Why is it important?
Because we will be giving the child, we will be putting the child on steroids. So
Okay.
if the child is having tuberculosis, it will be flared up.
Okay, very good. Well done. Fantastic. Yeah, please move on.
Socioeconomic history.
Yeah.
He lives in a paka house. Father is a driver. His education is still 12th standard. Mother is a housewife. She has studied up till 12th standard. They are living in a Pakka house with open sanitation. Number of rooms is 2. Number of persons in the family is 4. So according to the modified Kupasam scale, they belong to lower middle class.
Okay.
So summary, here is a 3-year, 10-month-old developmentally normal male child of birth order 1, born to non-consanguineous marriage, was brought with chief complaint of puffiness around the eyes and face for 10 days. Progression to involving the lower limb and upper limb since 5 days. So abdominal swelling was present for about 2 days with reduced urine output, no hematuria, hypertension, or symptoms of cardiac failure. With above history, I would like to think in terms of first episode of idiopathic nephrotic syndrome, most probably of minimal change nephrotic syndrome.
Okay, I think here I need to tell you that going for minimal change nephrotic syndrome is probably a bit far-fetched, even based on history, because please remember, that's a diagnosis based on it's a pathological diagnosis. See, we commonly equate nephrotic syndrome in children to MCNS, okay? But it is something which should be avoided because MCNS is actually a pathological diagnosis and not a clinical diagnosis, okay? So I think you are probably better off in sticking to a until maybe the idiopathic nephrotic syndrome. Okay, fine. So move on. Let's see what you get it onto history. Unless Dr. Karpaya, do you want to ask anything else?
Why you are mentioning is a idiopathic nephrotic syndrome based on your history?
Couldn't find out any secondary causes.
Underlying cause cannot be found.
Like torch infections were not seen in the mother.
Okay.
And there is no significant secondary causes like autoimmune disease in the family.
Okay. And what are the other negative history you asked to elicit the secondary causes?
History of fever, rash, joint infection, rule out SLE. And history of antenatal infections in the mother to rule out torch infections, which will lead to congenital nephrotic syndrome.
Okay. Can you name some infection will cause nephrotic syndrome other than congenital?
Toxoplasmosis.
No, other than congenital infection, any other infection will cause nephrotic syndrome?
Hepatitis B virus cause.
Okay. Malaria. Good.
Measles.
Okay.
Hepatitis B virus.
Okay. HIV also will cause. Okay, good. Go ahead.
Okay, just one more thing. No, just again, because you are so dogmatic, I am saying that this child has got a congenital nephrotic syndrome. Okay, how will you refute?
Less than 3 months will be the congenital nephrotic syndrome.
Okay, so it can go up to 1 year. Probably that's one very important point. Anything else?
Then during antenatal period itself, we'll have some findings, sir.
Okay, what finding you can have in antenatal period?
Polyhydramnios, oligohydramnios will be present.
Okay, for oligohydramnios, sometimes. Okay, fine. Not polyhydramnios, but oligohydramnios. Then, what happens to the renal function?
Mother may have some infections.
Remember, this is a 3-year-old child, isn't it? What happens to a child with nephrotic syndrome? Sorry, congenital nephrotic syndrome, surviving for 3 years? Almost all of them will be by now would be dead or would be on end-stage renal disease. Okay, so you'll get all the other features of renal failure which we are not getting here. Okay, so please move on.
General examination. Child is conscious, oriented, no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy. Anasarca is present. Bilateral pitting pedal edema up to the knee is present. Vital 98.4 degrees Fahrenheit. Pulse rate 88 per minute. Regular rhythm. Normal character and volume. No radial delay. No radiofemoral delay. Respiratory rate is around 24 per minute. Blood pressure is 88/50 mmHg. It is measured in the right upper limb in between posters. So it is around 50 to 90 centile. It's normal blood pressure. Blood pressure will be elevated in nephritic syndrome. So probably this may be a nephrotic syndrome. Saturation of oxygen is around 97%. That can add.
In
So
which condition?
Yeah, go ahead. Yeah, please go ahead. Yeah.
In which condition we will get a radiofemoral delay?
In the examination of aorta, we can get the radiofemoral delay.
Correlation of aorta. Okay. Can anybody tell other use of blood pressure cuff? One common infection in our area. We will do one of the tests.
Mohan, if you're
Fine.
around.
Filariasis.
No, to find out increased capillary permeability.
Filariasis.
What test and what disease?
Filariasis kadayadma. Too many
Very
mosquitoes
common.
in our country. What is HESS test? HESS test.
Sorry.
Hello, Professor, is it audible?
Hello, yeah?
Yes, sir. It's a tourniquet test, sir.
Okay, yeah, tourniquet test. So what is it? Where is it useful?
Hypocalcemic tetany.
Okay, that is one, right? Anywhere else? What we are talking about is some other infection, where it really is useful. See, before COVID came, what was the most dominant infection in the last 2-3 years, at least in Pondicherry and Chennai and all this part?
Dengue.
Dengue, yappa. Literally, we had to get into your larynx to get the word out. Okay, please. Okay, fine, go ahead. Sorry, can I just ask you? No, just go back. Just go back. I'm just being naughty here. You have mentioned about clubbing, isn't it? Why did you mention about clubbing? Anybody? Can you think of any condition where you can see clubbing and also associated nephrotic syndrome? It's a very difficult question. Almost. In children, there are possibly two conditions. One has been just discussed by Dr. Karpaya, just now he told. Okay, in children with HIV and associated interstitial pneumonitis, they can have clubbing. Okay, that's one. The second one is if there is in secondary nephrotic syndrome, particularly due to sickle cell anemia, there you can see some clubbing. Otherwise, it's very unusual. Okay, fine. Anyway, we'll move on. It's just really out of your realm. Okay, just move on.
End is normal in size and shape. Face periorbital puffiness is present. Facial puffiness is present. Eyes are normal, no cataracts. Mouth, oral cavity, no caries, normal. Skin, no rash, pyodermal scars. Neck or trunk is normal. Abdomen is distended. External genitalia is normal. Spine is normal.
Okay, fine. Where all you looked for the edema? You said it's anasarca, isn't it? Where all you look for?
Above the medial malleolus.
Okay.
In abdomen.
Okay. Abdomen, where in the abdomen? We are talking about fluid or something else?
Very abdominal wall edema.
Abdominal wall edema. So, okay, fine. So, how did you look for abdominal wall edema? The easiest way to do.
Using
Yeah,
a
you put a stethoscope, press and then say, okay, fantastic. Fine. Where else? Where else you look for? So, other sides you probably need to look for. One would be scalp. And in a child who is lying down, you have to look at the back as well. Okay, always remember to look at the dependent position because it's a dependent edema. Okay, so from top to bottom, so it will be the scalp. Then you need to look at the face. You look at the abdominal wall. You look at the back presacral edema, and then you look at the genital edema, and also you look at the pedal edema. Okay, please move on.
Weight for age, observed value is 13.9. So according to Z score, it is between -2 to -2. Height for age, observed value is 95, which is between -2 to -0. Sorry, -2 to 0 standard deviation. It is also normal. Weight for height, at 0 is standard deviation, which is normal. Mid-arm circumference is around 15.5. So it falls under 0 to -1 standard deviation, which is normal. Head circumference is around 47.5 centimeters. So it is around, it is between -1 to -2 standard deviation, which is also normal. So all the parameters are normal.
So you really think the weight of 13.9 in almost a 4-year-old child, is it normal? So what is the formula to arrive at the weight?
Which formula?
Yeah.
Each formula.
Yeah.
Age into.
Okay, age in years.
Age in years into 2 plus 8.
Sorry.
Age in years plus
into 2 plus 8.
Okay.
So the expected weight is for 4-year child, it is 16 kg.
Yeah, it will be much more than that actually. Okay. So I'm not very sure. And please remember, this child is quite edematous, isn't it? So if you look at the actually, there are different formula to use. The one, if you can kind of use it, so it will be around, I would think around 16 to 17. So probably on the lower side. So this child is probably having a acute malnutrition. Okay, so move on. So it's not normal. So and again, can you rely on the mid-arm circumference on this child?
No, sir, because of edema.
Yeah, you shouldn't really be trusting the mid-arm circumference. Yeah, move on.
Edema to subside, then we should assess the nutritional status. Can you define severe acute malnutrition?
More than 11.5.
Weight for height is less than 11.5. Mid-arm circumference is less than 11.5.
Less than 11.5 centimeters. And bilateral pitting edema.
Okay.
Weight for height less than -1 standard deviation.
-3. Severe wasting with edema and mid-arm circumference less than 11.5 centimeter. Okay. Can you anybody tell IAP classification of IAP classification based on the weight?
No. Anybody else who would like to contribute? Manimaran Ravi, Madhivanan Ravi, Merlin. You guys are around? Yeah, say right. Then I think we probably have to skip that. We are running short of time. We just move on. Please go ahead.
Yes, sir. IAP, hello.
Yeah, please go ahead. Yeah, Sollupa.
Yes, sir. IAP classification, it is normal above 80 percentage, sir.
Very good.
81%, 81 percentage.
Yeah.
And grade 1 is 71 to 80. Grade
Okay.
2 61 to 70.
Okay.
Grade 3 51 to 60. And
Okay.
below 50 it is grade 4 malnutrition
Okay, fine.
based on IAP.
Okay, fine. What is welcome classification?
Welcome as weight below 60 to 80 it is underweight. Below 60 it is marasmic child.
Okay. Then 60 to 80 with edema is?
With edema is quasi-okay.
Okay, and less
Without
than 60
edema is
with edema
underweight, and
is?
less than 60 without edema marasmus, and with edema is marasmic quasi-okay.
Okay, very good. Okay, fine. Yeah, move on. Well done.
Examination. GIP examine the boy is examined with supine position. On inspection, abdomen is distended uniformly, flanks are full. All quadrants of the abdomen move equally with respiration. Umbilicus is in the midline with a slit chest. No scars, no dilated veins, no visible peristalsis, no pulsation. Terminal orifices are normal and free. External genitalia is normal, no edema. Patient, abdominal width is 56 centimeters. Soft, not warm, not tender, no rigidity. On deep palpation, liver was just palpable. Liver span is around 6 centimeters. Spleen not palpable, no other mass.
Yeah.
Other systems, in cardiovascular system, S1, S2, no.
No, your slides are not moving. Okay.
Yes, it's stuck in wait for age for boys. Chart itself with that stuff.
It will rectify now.
Okay, while we wait for her to join in, I mean to yeah, okay.
Is this, that visible?
Yeah. Can you just go back on one of your slides? Okay, fine.
And here, sir, systemic examination. Can I resume it from systemic examination?
Yeah.
On inspection, abdomen is distended uniformly, flanks full. All quadrants of the abdomen move equally with respiration. Umbilicus is in the midline in the slit shape. No scars, no dilated veins, no visible peristalsis, and no pulsations there. Other orifices are normal and free. External genitalia are normal, no edema.
But you said that this child has anasarca, isn't it? So you should have told generalized edema, not anasarca then, if there was no genital edema. Okay? Fine.
Correct. Systemic examination on palpation, abdominal width was 56 centimeters. Soft, not warm, not tender, no rigidity. On deep palpation, liver just palpable. Liver span is around 6 centimeters. Spleen was not palpable. No other mass is felt. Other systems, cardiovascular system, S1, S2 years, no murmurs. Respiratory system, normal
No,
vesicular.
sorry, you said liver span of 6 centimeters. It looks a bit small for a child of that age. So I would just be careful when I mention the name liver span. That would probably be a 1-year-old child's liver span, 6 centimeters. Okay. So you need to be a bit more accurate. Okay. Fine. Please go ahead. I'll come back to this later. Yeah, please go ahead.
In respiratory system, normal vesicular breath sounds here, bilateral equal air entry, no added sound. Central nervous system, no focal neurological deficit.
Okay, fine. Can I just make two comments here? One is when you talk about S1, S2 heard, that is one of the most, I think, not the great way of commenting about the cardiovascular examination. Okay, because we want to know is the first and second order sound is normal, not just if it's heard or not. Can you think of a condition in nephrotics or a condition where S1, S2 is not heard? When you normally not hear a S1, S2? Yeah, anybody? Like, I think it comes by nature. No, everybody puts it S1, S2 not heard.
Any splitting is there between the S1, S2 like that, sir?
No. I'm just asking, think of conditions where somebody S1, S2 is not heard.
In case of dextrocardia, cytopenia.
Very, and then you would have said S1, S2 is heard on the other side, isn't it? On the right side. See, the most common cause is obviously the fellow is dead. Okay, that's probably the reason why somebody is not going to hear S1, S2, isn't it? So any live person, you would think of hearing a S1, S2. Apart from that, you can get muffled S1, S2 when, let's say, you have a very severe pericardial effusion. Okay, you can hardly hear it, or in marked obesity, or in a child with, let's say, a very, severe tension pneumothorax where the heart gets shifted over to the other side or something like that. But even all these conditions, you will at least hear a muffled S1. Okay. So one of the things you should learn to avoid is to stop saying S1, S2 is heard. Okay. You should learn to comment, is it normal or abnormal? Okay. So you can say normal first and second heart sounds and no murmur rather than a S1, S2 is heard. That's one. And the same thing which I always like to comment about the respiratory system also is about air entry. Okay. How do you know that the air entry is equal or not? Please remember, air entry is a physical phenomenon which we don't see. What we do is you look for the breath sound. So you have to say whether the breath sounds are equally heard on both sides, or is it loud on one side or loud on the other side or whatever. Okay. So you cannot say air entry is equal. Again, it is something which we have been taught when we were students. So I still insist. Okay. Fine. Please move on.
Systemic examination of your abdomen. You have completed the palpation for percussion findings of abdomen. Shifting dullness was present. Auscultation, normal bowel and bowel sounds.
Now, can you just go back? No. Can you just go back onto this? Again, another important point. No, onto the shifting dullness. How did you look for shifting dullness?
First, we will make the baby to lie in supine position, and I will focus from midline to the laterally towards the flank. So I will be getting a normal note on the flank. Sorry, sir. On the flank, I will be focusing from midline to laterally. The flank will be dull if there is fluid accumulation. So I will identify that particular area and I will fix that area with my hand, flexing of fingers, and I will gently move the child laterally. And I will wait for some few minutes, like 2 to 3 minutes, so that the fluids from this area will be collected the opposite side. So again, I will focus in the same area. Now I will be getting a tympanic tone. So which indicates that fluid has shifted to the opposite.
Why do you get what is the cause of the tympanic node?
Bowels will be pushed.
Okay, so bowel will start floating and that will cause. Fantastic. So any other method of looking for fluid in a child like this where he has got a gross abdominal distension?
Fluid thrill.
Okay, so did you look for a fluid thrill?
How do you look for? So I will ask. You mean the procedure, sir?
No, ma. I'm asking, did you look for a fluid thrill in this child?
Yes, sir.
Yes, sir.
No, sir, not necessary.
Okay, so you looked for and it was not seen. Okay, fine. Fine, move on. The reason why I asked you is because shifting dullness is a lot more difficult procedure to do in a small child. So if you can elicit a fluid thrill, you probably don't need to look for a shifting dullness. Okay, so please move on.
Diagnosis. So this is the first episode of anasarca with oliguria, most probably of renal etiology without hypertension and hematuria. So we are ruling out the nephritic cause since hypertension and hematuria were absent. So this is most probably an idiopathic nephrotic syndrome without any complications, without protein energy malnutrition. Am I audible, sir?
Yeah, you're audible. I'm just waiting. Dr. Karpaya, do you want to ask anything?
Yeah. So how much fluid required to shifting dullness to be positive?
1000 ml of fluid.
In fluid thrill?
1500 ml.
500 ml.
Okay. But one more sign, we will do that very minimal fluid. If the abdomen having very, very minimal fluid, what sign will do?
Sign we can do here.
Puddle sign, sir.
Puddle sign. Okay.
It will return about 50 ml of fluid, minimum fluid in that.
Okay.
Okay, fine. You
This is the end.
yeah. So your final diagnosis. So what are the complications you look for?
So, nephrotic child will develop edema. So that can be pleural effusion.
So okay.
Infections.
And
Any infection,
increased chance of infection.
embolism.
Hypercoagulability.
No. Sorry, I'm just not very clear. Clearly audible. Can you just repeat? What are the complications?
The first thing is edema.
Infection.
Then increased chance of infection.
Okay.
Then thrombosis,
Thrombosis.
renal vein thrombosis or pulmonary vein thrombosis or
Okay.
cortical thrombosis can occur.
Okay.
So there can be anemia because of hemodilution.
Fine.
And there can be hypothyroidism since the thyroid binding globulins are lost.
Yes, the hypothyroidism is very unusual, doctor.
Hypertension. Sustained hypertension.
So again, now coming back to what you said initially, how do you differentiate between nephritic and nephrotic syndrome clinically? So start with your history and go about with your your exam, include the examination also.
But the age of the child in nephrotic syndrome it is around 6 to 10 years, whereas in nephritic syndrome the child will be much younger than this age.
Sorry, the nephritis?
The child will be
The child is 2 to 6 years of age, sir. Nephritic, somewhere around adolescent age you can.
Okay, so older children in nephritis, whereas younger children in nephrotic. Fine. Number one. Yes. Number two.
In nephrotic syndrome, edema will occur first, followed by oliguria. Whereas in nephritic syndrome, the child first will develop hematuria and oliguria, then the child will develop edema.
Okay, fine. So edema is, oliguria probably starts earlier in nephritic when compared to nephrotic. Then hematuria, where is it more common?
Nephritic.
In nephritic. So in which type of nephrotic syndromes do you get hematuria?
Lesions.
Significant lesions.
Focal segmental glomerulosclerosis.
Okay, so in primary nephrotic focal segmental glomerulosclerosis, then
with the secondary is like SLE.
Oh no, apart from that, which are the other primary nephrotic syndrome types where you can get hematuria?
Membranoproliferative glomerulonephritis.
Okay.
Membranous glomerulonephritis.
Sorry? And membranous. Membranous nephropathy is relatively uncommon in children. It's more common in adults. Okay. Fine. So focal segmental glomerulosclerosis, mesangial-proliferative and membranoproliferative. Okay. Fine. And then secondary, yes, very often you can get hematuria. Fine. Then hypertension as well is more common in nephritis when compared to nephrotic. Okay, fine. Then move on. So how will you prove your diagnosis?
I will order for urine examination like spot protein creatine ratio.
Sorry?
Urine albumin, spot protein creatine ratio. I will order
Rate of
investigation.
okay. Before that, define a nephrotic syndrome. How will you define nephrotic? What are the 4 components of nephrotic syndrome?
Characterized by proteinuria, macroproteinuria, 3 plus 4
Okay.
plus proteinuria, isoalbuminemia, anasarca,
Okay. Okay.
hypercholesterolemia, more than 200 milligrams per deciliter, hypercholesterolemia.
Okay. So anasarcala, edema. So edema, you have to have proteinuria. You should have hypoproteinemia, and of course you should have. You can have hypercholesterolemia. Okay. So how much of proteinuria has to be there? How will you prove it?
Early morning sample 3 plus or 4 plus by
Greater than
dipstick or
40.
isosalicylic
Yeah,
test.
yeah. Abhilasha, can you just say again?
Greater than 40 per meter square per hour.
Okay, 40 what?
40 milligram of urine albumin
Milligram.
Greater than 40 milligram per
per meter square per
square
hour.
per hour. Okay,
And
fine.
3
also
plus 4 plus
protein and creatinine ratio more than 2 milligram of creatinine.
No, see, more than 2 creatinine protein ratio, more than 2. Okay, fine.
hypercholesterolemia is less likely in nephritis. So common with
Okay, what does
nephritis.
hypercholesterolemia indicate? So what type of proteinuria you get in minimal change disease?
Electroproteinuria. Only the albumins are
There is
normal.
some disturbance somewhere. I don't know from where it is coming.
Yes, sir. But through electron microscope histology, we can find it, sir.
No. I don't have electron microscope. All I have is clinical simple things, sir. So kindly we'll stick to simple things. So you said proteinuria, you could do a urine routine to look for proteins. So what is the test you use for looking for proteins in urine?
Urine dipstick test.
Okay, you're all modern people. Anything else, sir?
Sulfosalicylic
Urine
acid.
albumin.
Heat coagulation test.
Okay,
Boiling
heat coagulation
test.
you can do. Fine. So how will you categorize 1 plus 2 plus 3 plus and 4 plus on heat coagulation? Anybody?
Brick red is plus 4, sir.
Sorry?
Brick red color is plus 4.
Mama, that's the Benedict's test. I'm talking about heat coagulation.
Turbidity.
Anybody else?
First, we have to heat the urine, sir. The sample.
Yeah, heat coagulation. How will you look for? I guess you would have done it during your biochemistry, isn't it?
Yes, sir.
Marandachi.
We should fill the 3/4 of the test tube with the urine, and we have to eat the upper part of the test tube. Then the precipitate will be formed. Then after that, we should add 5 drops of 5% acetic acid.
Okay, fantastic. Yeah. Fine, you still get something white at the top. So I'm just saying, because she was so much obsessed with 3 plus and 4 plus. No, I'm just asking how will you find out if it's 3 plus or 4 plus? Fairly simple, one complicated. Very, very simple question. So what you do normally is you put up, you write something at the back and try to see through it how transparent or how opaque it is. Okay. If you just get a minimal turbidity, then without, and you can see it very clearly, it will be 1 plus. And then as the 4 plus will be totally opaque, you just can't say anything. Okay. So that's how you would make the other thing is to look at the urine dip, which you can also do. Okay, fine. So if let us say you get a 4 plus on your urine dip, what does it mean?
There is massive protein loss in the uterus.
So how much? Quantify it. Can it be? It's kind of it also acts as semi-quantitative measure. So how much protein is you're losing? Any idea? More than 1000 milligram per liters. Okay. If it is 3 plus, it is anywhere between 300 to 1000 milligram. If it is 2 plus, it is 100 to 300. And if it is 1 plus, it is 30 to 100 milligram per liter. Okay. Fine. So we looked at proteinuria. You wanted to look at the blood. What test would you like to order in the blood for this child?
Serum albumin levels, lipid profile. Am I audible, sir?
Yeah, you're audible.
Serum albumin levels, lipid
Okay.
profile,
Okay.
complete blood count, hemoglobin estimation.
Okay.
Then renal function test.
So
Urea
you want to
test.
look at the renal function test. You want to look at serum albumin levels. You want to look at cholesterol levels. Okay, fine. Fine. Anything else?
Manto test you have to do, sir.
Okay, you want to
Serology,
and then anything else?
serological tests like ASO titer, anti-nucleus antibodies. So rule
Okay,
out
that is to do
SLE.
the differential diagnosis. So in this child, probably I will not do ANA or ASLO because it looks quite Bandor, isn't it, nephrotic syndrome? So I will not be too worried. Anything else from a treatment point of view, which you probably don't think commonly, but it is important. One is he said tuberculosis. You want to do a MAN2, you'll probably do an X-ray along with it. Anything else? Any other viral infection we should be worried about in a child who is taking steroids? We should be very careful.
Varicella.
Yes, very good. So if you have the facility, you should also look for varicella antibodies. Okay, fine. Dr. Karpaya, do you want to ask anything else?
Yes, sir. Can you unmute me?
Yeah, you're audible. Yeah.
Hello?
Yeah, I can hear you. Yeah.
So what are the findings you look for in urine microscopic examination?
In nephrotic syndrome, there will be
Hyaline
island cast,
cast.
Okay.
granular cast in parenchymatous glomerular pathology,
Okay.
and the RBC cast in UTI, urinary tract infection.
RBC cast in UTI.
RBC cast in UTI, sir, and RBC cast like in nephrotic syndrome or post APGN.
Okay. Did you do complement level? What is the importance of complement level in this case?
We will look for C3 levels first.
Okay.
It will be normal in nephrotic. In our case, it will be normal. If it is reduced, we must suspect some focal segmental glomerulosclerosis and
Okay. Post-glomerulonephritis, what is the C3 level?
It will be reduced.
Increased.
Then what will happen?
Increased.
It will get deposited in the glomeruli.
No, C3 is low. Okay, fine. What will happen after that? After 8 weeks?
Then it come to normal, sir.
Okay. Okay, go ahead.
We have reached the end of the.
Okay, so now how would you treat this child? I think we are also running short of time, so another 5 more minutes we'll kind of finish it, and then I'll discuss show you some OSCEs. So how would you treat?
This is the first episode of our patient, sir. So I will start her on steroids, preferably prednisolone 2 milligrams per kg per day. It can be given as a single dose, a divided dose, early in the morning for about 6 weeks, followed by 1.5 milligrams per kg on alternate days, early in the morning for again for 6 weeks. So I will advise for salt restriction. I will advise for high protein diet. So I will explain the parents like but this condition can relapse after few days. So they must be very cautious in giving full course of steroid therapy because the first dose, first
So what are the
effect is
complications of the steroid therapy which you should monitor?
Fluid phases.
They monitor the
Cataract.
eyes of the child. Can be
Sorry?
short stature, eyes of the child, sir.
Okay, that is for in the long term, but in the short term, what are the problems you can face in a child who is taking steroids?
The child may show pushing white features, sir. I will look for pushing white features in the child.
Okay, even before that.
Proximal weakness of muscle limbs.
ஐயோ பா ரொம்ப யோசிக்கிறீங்க. Simple things. See, when you start giving steroids,
Gastritis.
yeah, gastritis is probably the first one I would be concerned about. Okay, and then what else? Infections, isn't it? So what are the infections? We talked about tuberculosis, or you mentioned about tuberculosis. We talked about chickenpox. Any other important infection in a child like this?
Pneumococcal infection.
Pneumonia.
Pneumococcal infections, very important. Okay, not pneumonia, more important than that. Some other important side. What other infection, pneumococcal infection, can occur in these children?
Spontaneous bacterial peritonitis.
Very good. Spontaneous bacterial peritonitis can happen. So why does it happen? Do you have any idea why pneumococcal is dominant in this condition?
Because the ascites will be there, sir. So the bacteria can grow well in the ascitic fluid.
Sorry?
Because of ascites, there can be the bacteria will proliferate more easily.
So why not any other bacteria? Why pneumococcus?
Because pneumococcus is a capsulated organism, sir.
Very good, very good. Yeah, it is a capsulated organism, and capsulated organism infections are more common in nephrotic. Why? It has to lose. It has to do with some loss of some particular protein.
Immunoglobulin.
Illa, something else. So you lose C5 complement and in the classical pathway, and also the proteins B and D. All of them are important for the opsonization and are important for killing of capsulated organisms. So not only pneumococcus but other capsulated organisms also is more common in these children. Okay, just not only pneumococcus. So how would but to prevent pneumococcus, what else you can give?
Vaccination.
Pneumococcal vaccination.
But you can't give it when the child is taking steroids, isn't it? Ideally, you like to give vaccines at least 3 months after you have stopped the steroid, because otherwise, no, vaccines itself can induce a relapse. So probably not. Anything else?
Immunoglobulin.
Very expensive.
Antibiotics, sir.
Acyclovir.
Antibiotics.
No, acyclovir, yes, you'll use, but only if there is exposure, if there is high risk, and that we are talking about varicella. I'm talking here about pneumococcal. How will you prevent pneumococcal infection? Something very simple, very cheap drug. Vaccine. Anybody else?
Gargling.
இல்லப்பா ஒரு சிம்பிள் ட்ரக் சொன்ன. Which antibiotic you'll use for treating pneumococcal infections? Penicillin prophylaxis. Yes, yeah, that's right. Somebody has written, just now mentioned penicillin. So these children, while the child is having severe edema, they can be put on penicillin prophylaxis. Okay, apart from steroids, that's something which you should consider giving for these children, particularly when they have massive edema. Okay, fine. I think we are running short of time, so thank you very much. Unless Dr. Karpe, you want to ask anything else and add, you might have another 3 more minutes, sir.
in nephrotic syndrome?
Emission, urine albumin nil or trace in 3 consecutive urine samples in a patient who is already having
Okay, how will you manage relapse nephrotic syndrome, relapsing child?
start on prednisolone 2 milligrams per 2 milligrams per kg per day till the urine albumin becomes nil or trace. Then I will start an alternative steroid therapy with prednisolone dose of 1.5 milligrams per kg per day for 4 weeks.
Okay. Okay. Thank you. Nice presentation.
Okay, thank you. Yeah, it's a very nice presentation. I think you guys did a very good job actually. Not fairly, nallave panninga. So I think you are well prepared and very good. Before I close, what I will do is now we'll move on to some spotters. Okay. It really is a spotter because I just want you to see some findings and more like an OSCE. Okay. So I'll just share my screen and then okay. I'll not necessarily go through all the slides, only some of them. I just want you to make the diagnosis and tell me how will you treat. What do you think is the problem in this slide? What you can see?
Scabies.
Okay, fine. So why do you think somebody said scabies? Why do you think your it is scabies?
The infectious vessels, sir.
Okay, so you get intertriginous area. You can get some papules like you can see here. Okay, you can see some papules here. Okay, and also surrounding, it's a infected scabies. Okay, so think of, can you tell me one systemic complication of infected scabies? Fast spot alone, the more, I mean, we'll stop exactly at in another 9 minutes. Post-epilogue glomerular nephritis. Okay, please remember that is something which you have to think of. That is the reason why you have to treat a child with scabies. Apart from the fact that there is severe itchiness, they can't sleep. Okay, this is something you have to always consider treating. Okay, and how will you treat a child with scabies?
Permethrin.
Okay, you could use permethrin. How many percentage? Any idea? So you'd use 5% permethrin. Okay, and how long you'll keep it? So you should apply it all over the body below the neck. Okay, and then between the intertriginous area, in the groin and all the and then leave it for at least 12 hours. And then the following day, the child has to be given a complete bath. And more important than that, you should not just treat only the child, but also treat rest of the
family members.
Okay. So let's say this family has got an older child, let us say a 10-year-old, and then they say I cannot bother to give permethrin. What other option is available? Can you think of oral drug which can be used? Yeah, very good. Ivermectin. Okay, fine, fantastic. Okay, fine. We'll move on to the next one. What do you think this child has got?
Varicella.
Yeah. Problem is, this is something which you don't see very easily. You see probably the face part, but not these vesicles or bullae.
Impetigo, sir.
Yeah, this is a bullous impetigo. Okay, and this thing very often because
Honey crust appearance.
Yeah, you get the classical honey crust appearing on this side. That is here the bullae breaks. Okay, again, very common childhood infection you think about. And what is this child having?
Marasmus.
Okay, fine. Yeah, this is something. So obviously, all the features of marasmus are. You got a very irritable, okay, wasted child. Okay, so who is obviously skin and bones. Okay, and this is a child with marasmus. What is this child?
Kwashiorkor.
sir.
Okay, fine.
Short,
Obviously,
belly, erythematous.
yeah. So he looks quite healthy, isn't it? He looks quite chubby, but actually he's not.
Edema.
You can see the edema both in the hands and the feet, and even in the facial puffiness is there. We are not able to see the dermal changes, other dermal changes, but you can see the sparse hair here. So this child has got. So here you can see the dermal changes. Okay, the crazy pavement dermatosis, which you see in children, and here you can see obviously this child is quite sick looking, isn't it? So what is this you are seeing here? White hot spots. Okay, so on the top is white hot spots, at the bottom is keratomalacia.
Malaysia.
Okay, so how would you treat it?
Vitamin A.
Vitamin A.
So how much vitamin A you will give?
1 lakh.
Sorry?
1 lakh units.
So how, for children less than?
For children less than 12 months, sir.
Okay.
And above 12 months, 2 lakh international units.
And about to so how many doses would you like to give?
If on first day we have to 3 doses, sir. 0, 1, and 30.
0, 1 and
30. 4 weeks.
okay, 2 weeks. Okay, so you give 2 lakh units for a child more than 1 year, and 1 lakh units for a child less than 1 year. On day 1, that is today. I mean and then one more dose the following day, and then one more dose after 2 weeks. Okay, fine. What is it you are seeing here in this child?
Rachitic rosary.
Okay, so you could see, obviously you could see the bow legs here, and then you can see the rachitic rosary. Okay, fine. Anyway, I'll just skip. I will not discuss in detail. Okay, what do you think this child has got? You describe the findings and tell me the diagnosis.
Hypothyroidism.
No, I said describe the findings.
He has got ascites.
Sorry, first picture, what does it show? Okay, so in the first you can see a very kind of coarse faces. Okay, you find a child who is fairly hypotonic. Okay, so there's not much of flushed posture, isn't it, in this child? You see a bit of abdominal distension. You see a bit of umbilical hernia, and then in this picture you can see the macroglossia which is happening. So obviously this is a child who is a congenital hypothyroidism. Okay, please remember this is the most important cause of preventable mental retardation in children. Okay, any other cause of preventable mental retardation you know of? Yeah. So another inborn metabolism like phenylketonuria, yes, fine. If you identify early enough and treat, you can avoid. Then jaundice by itself, kernicterus. Okay, yeah, if you can treat it early, it will be can prevent it. Okay, a huge lot of costs. Then you will skip. Okay, this will skip. What do you think this child has got?
HSV,
So, okay, so you think this is a Hanoch-Schönlein purpura. So what is the classical description of this particular rash?
Only in the lower limb you can see the rashes.
Okay, so you get a palpable. Palpable. What else?
Large palpable rash.
Okay, large. Okay, palpable rash. Something else. Is it blanching or non-blanching? So obviously purpura, so it has to be a non-blanching rash, isn't it? So it's a non-blanching palpable rash, which is predominantly seen at bony prominences and where there is maximum contact of the skin to the external surfaces. Okay, to the underlying external surfaces. So that is why you see here that where there is not much contact, like in the back of the knee, you don't get the rash. Okay, so it's only in places where you get, again in the elbow, you don't get it. So again, there is a reason for it. I'm not going to discuss in detail about it, but so basically, it's a non-blanching palpable rash. Okay, which is which you get in bony prominences and the places where there is maximum pressure points. Okay. So what do you think this child has got?
Mongolian spot.
Okay, so you think this child has got a Mongolian spot. Okay, fine. So if a mother comes to you with this condition, what would you tell her?
It is mostly
No treatment
normal,
is
sir.
needed. We can give
No
only
treatment is
reassurance,
required.
sir.
Okay, so
Up to 4 years we can wait, sir.
so not a this is a kind of benign condition. It will disappear by itself. Okay, probably by about 1 to 1.5 years. Okay, do you know? So Mongolian spot is actually a kind of we are branding somebody, isn't it? So is there an alternative name for this condition? A more scientific name? No. So the other this thing name is actually a congenital dermal melanocytosis. Okay, that is the kind of scientific term for this condition. I think we have reached time, so I'll stop here. Though I got a lot more slides to talk about. Maybe next sometime later we can discuss it. So thank you very much. So any other questions you want to ask or anything else, we are open for discussion. I think if nothing else, we'll stop. Sir, Rajan sir.
Yeah. Okay, I think it's a wonderful case presentation. I think Dr. Tirumurugan, as usual, Karapaya Pandey, both are youngsters. I think they discussed very well, and Abhilasha as well as Ariv Madi, both they are interacted very well and presented very well. Dr. Ariv Madi, I think a more interactive session today. I think Tirumurugan usually says no, we should have an interactive session. I think he has implemented today. And I think most of the students also they put chat box. No, I think did you see the chat box?
Yes, sir. They were answering actually, and they actually, as said, no, sir. Today the interaction is much better than what it normally is. Actually,
Yeah.
It's very nice.
Yeah, I think the spotter also it is good. Okay, nice spotters relevant to this presentation. And again, it's my great pleasure and privilege to tell the word thanks to Dr. Karupaya and their students and Tirumurugan for a wonderful presentation. Thank you, one and all. Thank you.
Thank.
Tirumurugan, today night we are having PG case presentation.
Sir.
Yeah. So I think undergraduate also they can join.
Yeah, they can join. Actually, it is quite useful if you guys can join in to look at the so PG topic discussion. It is quite useful, and it's all about. I don't think the patient ever presents to saying I'm a postgraduate case or undergraduate case. He presents to you with the problem, and it is really useful to learn more. And the discussion is pretty much very good in those the discussion. Particularly today's case on cardiac, I think you should really join it because the chairperson, Dr. Jnanasandhan, is really fantastic. I mean, the last time when I heard to him, I mean, he was really good. So I think you'll benefit from joining those classes.
The undergraduate students they can join with postgraduate specialist. I think you should start with basics only. Whatever things like whatever things you want, you can take it. That's all. Okay. Thank you, everybody.
Yes, sir.
Thank you, sir.
Okay.
Thank you, sir. Thank you, sir.
Karupaya, you want anything? Tell anything? Dr. Karupaya, do you want tell anything?
Send me that post graduation discussion link, sir. Make sure our students will join, sir.
Okay, thank you.
Thank you,
Yeah,
sir.
yeah,
Thank you,
I'll share it to you now.
sure,
Yeah.
sir. So very
Thank you.
nice
Thank you.
presentation. And it's a nice time.
Okay,
Thank you,
nice.
sir.
Okay, thank you.
Yeah.